Good evening, everyone. So my next video is on the topic calcium metabolism and osteoporosis. Now I'm going to discuss with you treatment of osteoporosis basically and calcium metabolism. And before I start my video, I want to request you, if you like my video and if it is useful to you and helpful to you, kindly subscribe to my YouTube channel. That is Dr. Nitika Hans Pharmacology Discussion. So now I'm going to start with calcium metabolism and osteoporosis treatment. Now, what is calcium? Calcium is an intraosseous cation, 99%, and extraosseous fraction is only 1%. Intraosseous means inside the bone it is present. 99% of it is present in the bone, and only 1% of the fraction is present in extraosseous region. The level is essential for normal body function because of the effects of neuromuscular excitability and cardiac muscle. It is responsible for normal body function. It can have the effect on neuromuscular excitability and on the cardiac muscle. Calcium it also acts as the enzyme activator. Hypercalcemia can lead to muscular hypotonia, cardiac arrest, and arrhythmias. Hypocalcemia can lead to tetany and arrhythmias. Now, where it is found? Calcium is found in the milk and dairy products. It is also available from other food sources such as green leafy vegetables, seafood, salmon with the bones provide an even greater dose. Almonds, broccoli, figs, soybeans, tofu, all these contain calcium. Body requirements are in the age 1 to 3, the requirement is 500 milligram. In the age 4 to 8 years, the calcium requirement is 800 milligram. In the age 9 to 18 years, calcium requirement is 1300 milligram. In the age 19 to 50 years, the calcium requirement is 1000 milligram. And in the age 51 plus, the calcium requirement is 1500 milligram. Pregnant and lactating women are recommended a daily calcium intake of 1000 milligram. Different forms of calcium. At any one time, most of the calcium in the body exists as the mineral hydroxyapatite. It exists as mineral hydroxyapatite. Calcium in the plasma, 45% is ionized, physiologically active form, 45% bound to albumin, predominantly to albumin, 10% complex with anions like citrate, sulfate, phosphate. Regulating factors. Now, in the regulating factors, when the blood plasma is ionized, calcium levels increase in the body. The thyroid gland releases calcitonin, and calcitonin is responsible for shifting the calcium from blood to the bone. So the serum calcium level decreases, it returns to normal. Calcium serum levels decreases because calcitonin is responsible for shifting the calcium from blood to the bone, and can be used in the treatment of the osteoporosis when the bone calcium level is reduced. When it falls below the set point, the thyroid gland release parathyroid hormone. When it falls and parathyroid hormone is released, and this parathyroid hormone is known to increase the plasma calcium levels because it causes bone resorption and it shifts the calcium from bone to the blood. Calcium receptors present in the parathyroid gland, kidney, brain, and other organs are also responsible for regulating the calcium level in the blood. Now, parathyroid hormone, it is the 84 amino acid hormone. It is secreted from the chief cells of the parathyroid gland. Basically, it increases the plasma calcium level because it causes resorption of bone, and it increases the renal phosphate excretion also. Increasing resorption of bone, and then it increases the renal tubular resorption of calcium. There will be more renal tubular resorption of calcium, and increase intestinal absorption of calcium, a slower response. It also increases the intestinal absorption of calcium. Increasing synthesis of vitamin D stimulates GIT absorption. Vitamin D metabolism, the active form of vitamin D is 1,25-dihydroxycholecalciferol. Its production in the kidney is catalyzed by 1-alpha hydroxylase. 1-alpha hydroxylase activity is increased by decreased serum calcium, increased PTH level, that is parathyroid hormone level, and decreased serum phosphate. All these will lead to increased vitamin D, and vitamin D is responsible for causing increased absorption of calcium from the GIT and reduced tubular excretion of calcium. And this calcitriol, which is vitamin D 1,25-dihydrocalciferol, it increases the calcium absorption, intestinal calcium absorption, increases intestinal phosphate absorption, increases the renal absorption of calcium and phosphate, and increases the absorption of bone. It also increases the absorption of bone, so serum calcium levels are increased. Calcitonin, it is produced from thyroid C cell, inhibiting of osteoclastic bone resorption. Calcitonin, it shifts the calcium from blood to the bone. So it inhibits the osteoclastic bone resorption, but it leads to formation of calcium in the bone. It also increases renal excretion of calcium and phosphate. Now, this is how the calcium metabolism is there. Whenever the calcium levels in the body falls, the thyroid hormone, the thyroid gland has the parathyroid glands, and these parathyroid glands, they release the parathyroid hormone, and this parathyroid hormone, it decreases the bone matrix, and it releases calcium into the blood because it causes absorption of bone, parathyroid hormone. So blood levels in the blood levels of calcium in the body will increase. And when there is increased levels in the calcium, thyroid gland releases calcitonin, and this calcitonin stimulates calcium salt deposition in the bone. It stimulates the calcium salt deposition in the bone. Calcitonin, because it shifts the blood calcium into the bone. So the bone resorption will, bone formation will take place. Deficiency of calcium levels in the body may induce several diseases like rickets in the children, osteomalacia in the adults, and osteoporosis. Now, what is osteoporosis? A systematic skeletal disease in which there is low bone density, microarchitecture deterioration of bone tissue that enhances bone fragility and increases the risk of fracture. Osteoporosis by WHO, a bone with low density and higher fracture risk. WHO utilizes bone mineral density as definition T-score less than -2.5, which is surrogate marker. Standard deviation of the bone mineral density from the average sex matched 35-year-old. Epidemiology: 1 in 3 women over 50 years they suffer from osteoporosis, and 1 in 5 men over 50 years suffer from osteoporosis. And 15% to 30% men and 30% to 50% men suffer fractures related to osteoporosis in their lifetime. Peak incidence: Western 70 to 80 years, India 50 to 60 years. Now, these are the constituents of bone. Matrix and cells. Matrix, organic and inorganic. Inorganic contains calcium and phosphorus. Organic contains collagen, mucopolysaccharides, and non-collagenous proteins. And cells are osteoprogenitor, osteocytes, osteoblast, osteoclast. Peak bone mass and osteoporosis. Peak bone mass is the maximum mass of the bone achieved by an individual at skeletal maturity, typically between ages 25 to 35, means which is the maximum maturity of the calcium obtained. And after peak bone mass is attained, both men and women lose bone mass over the remainder of their lifetimes. Means afterwards the bone mass reduces. Because of the subsequent bone loss, peak bone mass is an important factor in the development of osteoporosis. Now, determinants of peak bone mass are nutritional status, genetic factors, physical activity, gonadal status. With genetic factors, genetically, if the person is more susceptible to osteoporosis, the father and mother or in the family, if someone is more susceptible to osteoporosis, so that can lead to decrease in the peak bone mass. Nutrition status like calcium, dairy products, milk, and other green leafy vegetables, salmon, if they are not taken, then that can lead to decreased bone mass. Physical activity, if they are not exercising, do not having the healthy lifestyle, so that can lead to reduced bone mass. Gonadal status, reduced estrogen and testosterone levels in the body can lead to reduced peak bone mass. These are the modifiable risk factors: sex, hormones, low estrogen, testosterone, low calcium, vitamin D, inactive lifestyle, excessive alcohol, cigarette smoking, hyperparathyroidism, increased parathyroid hormone release that can lead to reduced calcium, hyperthyroidism, GI conditions which impair adequate nutrition, steroids, or Cushing's, proton pump inhibitors. Management of osteoporosis, it can be non-pharmacological, which can lead to prevention of the osteoporosis and osteoporotic fracture, nutrition, lifestyle modifications, prevention of fall, hip protectors, basic therapeutic measures like we can give vitamin D and calcium supplementation, and estrogen and hormone replacement therapy, which includes estrogen and progesterone. Anti-absorptive agents like calcitonin, bisphosphonates, selective estrogen receptor modulators, donisumab, and bone stimulation stimulators, bone formation, sodium fluoride, exogenous parathyroid hormone, vitamin D analogs, and drugs with dual action, means which stimulate the osteoclast and which inhibit the osteoclast and stimulate the osteoblast, that is strontium ranelate. Calcitonin is the drug which will shift the serum calcium from the blood to the bone. Bisphosphonates, these inhibit the osteoclastic activity. Some selective estrogen receptor modulators, they help in increasing the HDL levels, increase the bone formation, and they reduce the breast cancer risk and reduce the endometrial cancer risk. Denosumab is the monoclonal antibody against the RANKL ligand against RANK receptor, which is responsible for its stimulation, is responsible for osteoclastic activity, and when it is inhibited, it will lead to decreased osteoclastic activity. So decreased absorption of bone will be there. Exogenous parathyroid hormone, when parathyroid hormone in the blood will increase, so serum calcium levels in the blood will decrease. Vitamin D analogs, they will lead to increased absorption of calcium from the intestine and decreased excretion of calcium, leading to increased serum blood level, which will shift to the bone. Now, non-pharmacological treatment. Dietary changes for all individuals. A well-balanced diet with adequate calcium and vitamin D is essential for healthy bones. Calcium contributors: dairy, milk, dairy products like milk, yogurt, cheese, ice cream, cottage cheese, fortified orange juice, and soya products. Most vitamin D comes from sun-induced skin conversion, and vitamin D contributors: fatty fish and few unfortified foods. Pharmacological treatment: men aged 50 to 70 consume 1000 milligram per day of calcium, and women aged 51 and older and men aged 71 and older consume 1200 milligram per day of calcium. Intake in excess of 1200 to 1500 milligram per day may increase the risk of developing kidney stones, cardiovascular disease, and stroke. Now, vitamin D, 800 to 1000 international units of vitamin D per day for adults age 50 and older. Treatment of vitamin D deficiency is adults should be treated with 50,000 international units once a week for 8 to 12 weeks to achieve a 25 hydroxy dehydrocollocalciferol level of approximately 30 nanogram per ml. This regimen should be followed by maintenance therapy of 1500 to 2000 international units per day. Now, bisphosphonates. These bisphosphonates, these are the analogs of pyrophosphates. Mechanism of action is They attach to bone remodeling sites, causes apoptosis of osteoclast by disrupting cytoskeleton. Means these bisphosphonates are concentrated under the osteoclast, and bisphosphonates are released locally during bone resorption. And they will inhibit the osteoclastic activity and promote osteoclastic apoptosis. And they may also modulate the signaling from osteoblasts to osteoclasts. They will increase the osteoprotogranin protein production, means which stimulate the osteoblast, and they will decrease the Rankel expression, which stimulate the osteoclast. So Rankel expression will reduce, so stimulation of osteoclast will reduce, and they also cause osteoclastic apoptosis, and osteoprotogranin production will increase. That will lead to increased osteoblastic activity, and they accumulate in concentrate in the osteoblast, and they cause the release when there is more bone resorption, and they inhibit the osteoclastic activity, and they cause the osteoblastic apoptosis. These are the first generation bisphosphonates. These are atudronate, choledronate, medronate, talludronate. These are less potent and inhibit bone mineralization, that is, they inhibit both osteoblastic and osteoclastic activity. So these have been replaced by newer second generation, 1,000 times more potent than first generation and third generation bisphosphonates, which are 1,000 to 5,000 times more potent. So these are alendronate. Prevention, we give 500 milligram daily or 25 milligram weekly tablets. Treatment, we give 10 milligram daily or 70 milligram weekly tablets. Alendronate is also used in the treatment of osteoporosis in men and women taking glucocorticoids, that is steroids. Ibandronate treatment is 150 milligram tablet, 3 milligram every 3 months by intravenous injection. Ibandronate 3 milligram per 3 ml pre-filled syringe is given by intravenous injection over 15 to 30 seconds. Serum creatinine should be checked before each injection. Rezidronate prevention is 5 milligram daily tablet, 35 milligram weekly tablet, and 150 milligram monthly tablet. Prevention and treatment. Zoledronic acid or zoledronate, it is 5 milligram intravenous infusion over at least 15 minutes per once yearly for treatment. 5 milligram in 100 milliliter is given in intravenous infusion over at least 15 minutes once every 2 years for prevention. Drug administration, oral tablets should not be given early morning or empty stomach. Means they should not be given early morning, or they should not be given empty stomach, because if they will be given empty stomach, they can, oral tablets should be given early morning or empty stomach, because if they will be given in the food, they can lead to regurgitation, and when they are regurgitated in the esophagus, that can cause ulcers in the esophagus, they cause esophagitis. So they are taken 60 minutes before breakfast, or patient should sit upright for 1 hour. Why they should sit upright? Because in 1 hour the food shifts from the stomach to the intestine, and there is no regurgitation. Side effects, oral bisphosphonates, they cause the gastrointestinal problems such as difficulty swallowing, esophagitis, and gastritis. So that's why they're given with plenty of water, empty stomach, and plenty of water, because no accumulation in the esophagus takes place, and there is no regurgitation. So they're taken empty stomach, and they should not lie at least 30 minutes after taking the bisphosphonates. All bisphosphonates are contraindicated in patients with estimated GFR below 30 to 35 ml per minute, and they also cause osteonecrosis of the jaw, that is mandible, and can occur in long-term use. It can occur in long-term use of bisphosphonates. Although rare, a low trauma atypical femur fractures may be associated with long-term use of bisphosphonates. Example, more than 5 years of use. Now, calcitonin, which shifts the calcium from blood to the bone. So it is used in the treatment of osteoporosis at least 5 years, who are at least 5 years post-menopausal when alternative treatments are not available. 200 international units delivered as a single nasal spray, and when it is given intranasal, it can cause rhinitis, epistaxis, and allergic reactions. Very small increase in the risk of certain cancers. Hormone replacement therapies, estrogen and progesterone. These are good in the bone formation and it increase the HDL levels, but they're not effective in, they can increase the risk of breast cancer and they can increase the risk of thromboembolism, or they can cause deep vein thrombosis, or they can cause myocardial infarction. So these are not so safer lines of treatment for the osteoporosis. Also relieve symptoms of postmenopausal symptoms and vulvovaginal atrophy. Dose 0.625 milligram daily, but side effects, they are coronary heart disease, strokes, pulmonary embolism, increased risk of breast cancer, as well as endometrial cancer also increases if we give estrogen. But when we give progesterone, that risk is not seen. Overall health risks from estrogen exceeds the benefits from use. Some selective estrogen receptor modulators, these can be used for prevention and treatment of osteoporosis. Loxapine, it increases the bone formation, increases the HDL level. It reduces the risk of breast cancer and endometrial cancer, but thromboembolism is not treated. It causes deep vein thrombosis, hot flashes, and leg cramps. Parathyroid hormone, teriparatide, it is the 1 to 34 amino acid parathyroid hormone. It increases the osteoblastic activity, so it increases the bone formation. So it can be used in the treatment of osteoporosis in postmenopausal women and men at high risk of the fracture. Bone loss occurs if used alone, so given along with estrogen or synthetic androgen. And it is also approved for the treatment in men and women at high risk of fracture with osteoporosis associated with sustained systemic glucocorticoid therapy. Dose 20 microgram daily subcutaneously. Duration not exceed 18 to 24 months. When treatment is stopped, bone loss can be rapid and alternative agents should be considered to maintain the bone mineral density. Side effects are leg cramps, nausea, dizziness, constant decay. These can cause the osteosarcoma. And it can also cause bone metastasis, hypercalcemia, and increase the risk of skeletal malignancy. Denosumab, which is the RANKL inhibitor, means RANK is the receptor which when stimulated, it causes the stimulation of osteoclastic activity. And when the ligand against RANK is inhibited, so osteoclastic activity will not be stimulated, so bone resorption doesn't take place. So antibody, monoclonal antibody to RANKL inhibits the osteoclastic differentiation function of RANKL. So dose is 60 milligram per 6,000 subcutaneously, used in postmenopausal women. These are used in postmenopausal women. Side effects are hypocalcemia, cellulitis, skin rash. This is how the mechanism of action is there. This is the denosumab bound to RANKL. Its interactions with RANK is blocked. Means RANK, this is RANKL ligand. This is this rank ligand. The denosumab, it attaches to this ligand and it does not attaches to the rank receptor. So osteoclastic activity will not be there. So there will be more bone formation and multinucleate osteoclast will not be activated, and that can lead to reduced bone resorption and increased bone formation. Non-FDA approved drugs are sodium fluoride that facilitates osteoblastic activity and thus increases the bone volume. Strontium, it increases the osteoblastic activity, decreases the osteoclastic activity. So it prevents the bone resorption and increases the bone formation. So it promotes the apoptosis also. So it is the drug strontium ranelate. This is a drug. It has a dual activity. It can be used in treatment of osteoporosis. Thiazides, they cause hypercalcemia by inhibiting renal calcium excretion. They reduce the calcium excretion, increase the hypercalcemia that can shift to the bone. So thiazides can be used as the treatment of the osteoporosis. Thank you. That's all for osteoporosis and calcium metabolism. I hope you understood my lecture, my test video. And if you have understood my video, kindly subscribe to my YouTube channel. That is Dr. Nitika's Pharmacology Discussion. Thank you. Be happy, be healthy, be blessed. Happy learning. Thank you.